When I see patients with Chiari and syringomyelia, this is how I select them for surgery, and this is how I do it. So it's a bit like spine surgery. When we're trying to choose a patient for surgery, we have to work out what is it that they have. So I have to work out with a Chiari patient, given there are so many people that are asymptomatic, I have to decide, are they symptomatic or aren't they? There are so many differentials with a patient presenting with all these different symptoms. Then I have to know what is the natural history and also what are the different surgical procedures that we can perform and what are the outcomes of these surgical procedures, because they all carry a risk. And are they any better than doing nothing? And that's the hardest thing for a surgeon to do. Dr. Legaspi so eloquently talked about all the different types of classifications, etc. I'm an adult neurosurgeon, so I'm going to concentrate on the Chiari 1 malformation, which is the commonest by far. He went through the etiology and pathophysiology, so I guess once you have an understanding of that, then you can aim to combat the cause of their symptoms that are presenting as part of the Chiari. And that in itself is controversial. So what do you do? Well, the commonest, not sure why this is not working. No. I guess the key for me is to know what the natural history is. And there are many associations with Chiari 1 malformations, anything ranging from common to very uncommon syringomyelias, so syrinxes. They're most commonly found in the cervicothoracic region, obviously, being where the cord is. There are also craniocervical junction anomalies and scoliosis. Most people who have the definition of a Chiari malformation, however, a lot of patients who have Chiari malformations, even severe, quite significant tonsillar descent, are still asymptomatic. And there are some patients as well who don't have such severe tonsillar descent who are symptomatic. So I really think that taking a good history and talking to the patient at length about their condition and what you feel is going to offer them the best scenario is really important. So these patients can be symptomatic or asymptomatic, as Dr. Legaspi talked about. When they're symptomatic, they have the cervicomedullary compression and perhaps the other associations such as the syrinx itself and also scoliosis. The common symptoms, really most of them are the headache, the cough impulse headache that you'll get. So with respect to the patients who are symptomatic and not, the prevalence is very low because these cases are so rare. Of those patients who are asymptomatic, there's less than 5%, and of those that are symptomatic, there's less than 1% in the community. There's more than likely going to be many, many patients who have incidental Chiari malformations. You have a predisposition if you're female. You're more likely to have a syrinx if you've got peak tonsils, basal invagination and longer descent, and you're more likely to be symptomatic if you've had trauma, smaller posterior fossa, etc. The differentials range from intracranial hypotension to intracranial hypertension, tethered cord, etc. So you've got to work out in your mind whether this condition really is symptomatic. The thing that I sort of noticed in my evolution as a surgeon when I first came out was as soon as I saw a syrinx, I used to think, oh, goodness, we need to operate. This is going to become deadly very soon. But with experience and just with watching patients and reading up on things, I've changed the way I manage things. So there's lots of articles about the natural history. In summary, almost all of them remain unchanged if they're asymptomatic. If they're asymptomatic with a syrinx, they're also mostly unchanged. The syrinx itself usually remains unchanged. It can even get smaller. It can also get larger, which is why you need to monitor. And also there are cases of death and terrible catastrophes. But again, this is something that you would catch if monitoring closely. If you are symptomatic and you're pediatric, it's more likely they're going to be less symptomatic with time, and there's a higher likelihood of improvement. So usually the symptoms of headaches improve with time. Occasionally they worsen. But a lot of the time they're unchanged, along with a lot of the other common symptoms as well. So this is an example of someone I've been following for 7+ years. She was mildly symptomatic. She's got a little syrinx there, mildly symptomatic, had some headache and numbness, etc. And I had a chat with her and I said, more than likely you're going to need surgery very soon. She said she didn't want to have it. So I was monitoring her, and I'm now up to sort of 2-3 yearly exams. I last saw her in 2022 and she's completely fine. So what are the indications for surgery in my mind? I don't think there's any consensus, as you could see with Dr. Lagabi's very comprehensive talk. Usually the symptoms that would bring me to operate are if there's a significant cough impulse headache that patients cannot function, that it impedes their quality of life. If there's a large or enlarging syrinx, I get very, very nervous. And if there's neurological deficits or myelopathy, obviously. I think if the syrinx is changing, that's certainly something that triggers me to operate. So the outcomes of surgery, generally there are great improvements of symptoms with and without syringomyelia, and this more likely ties, in my mind, with the type of surgery that's performed. So usually the headaches and paresthesias, they all improve with surgery usually, but there is also an element that can improve with conservative management only. There is still a lack of validated outcome measures specific to Chiari, so a lot of it is your own experience and subjective opinion of what your outcomes are with surgery as to whether you continue on doing what you're doing. So the surgery that I would perform and that most people would perform is a craniectomy plus or minus a laminectomy, depending on how low the tonsils lie. A duroplasty is optional, but I think a lot of surgeons would do the duroplasty, and I certainly do it every case. You can use either synthetic dura or you can use autologous, a pericranium. Again, adhesiolysis is controversial. I do it every case. And tonsillar herniation or subpial dissection, I do that every case as well, because the cases I operate on usually have very tight foramen magnums. They're very symptomatic. So I think I just want to go in and do the operation, in my mind, as properly as I can. I don't do drainage of the syrinx or atlanto or any fusion procedures for Chiari 1 malformations. The complications of such surgery, as with any posterior fossa surgery, can be significant. I think the difference, as I do a duroplasty each time, these are articles comparing patients who've had duroplasty without duroplasty. They're pretty comparable with respect to the complications. Obviously, the pseudomeningocele issue is an issue with those that have duroplasty, but even then, it's not necessarily something that's long-term or symptomatic. The postoperative complications after using autologous versus synthetic, the pseudomeningocele and the CSF leak were obviously an issue, but they did find in this article that there was the risk of pseudomeningocele and CSF leak were much lower in using autologous duroplasty. And again, the clinical outcomes, the measurement of such are really, again, controversial as to what's the most reliable and reproducible. There's still no consensus. So in summary, this is how my sort of, I guess, treatment algorithms. If a patient's got a Chiari, whether they've got a syrinx or not, if they're asymptomatic, then I would monitor. If they've got mild symptoms and they're manageable, then I would monitor. If they've got a syrinx with mild symptoms, I'd monitor a little bit more closely. If they've got an enlarging symptomatic, particularly symptomatic syrinx, then they have surgery. If they've got a Chiari and they don't have a syrinx, but they've got significant symptoms and they are tight in the foramen magnum, I do surgery. And I've noticed you actually get quite good results with that. And patients, obviously, who are very symptomatic of the syrinx get surgery as well. So the technique is pretty standard. The key is patient selection in this case. That's the most important thing to determine, whether you've got it right and what your outcome will be. We do a timeout, which I think is a really important thing because things can go disastrously wrong here. So if we're all on board with the anaesthetist to tell them, things that could potentially happen, we could go into the sinus, we could get cerebellar herniation, etc. This is a difficult procedure. We also, I guess, convey to the anaesthetist, we're aware that there can be ventilation problems if you're doing this case prone, etc., air embolism, etc., to keep it, make sure that everyone's on board, because any posterior fossa surgery can lead to death on table, as we all know. I then do a position and scalp dissection, remove the bone flap and or laminectomy. I do a duotomy, I do an adhesiolysis, I cauterize the tonsils, and I then close the dura and the scalp. So this position I do, I have my patients in prone position, but I can appreciate having a patient supine would be really good from a spatial orientation and anatomical perspective. There is much better ventilation and hemostasis associated with the sitting position, but there's also a greater risk of air embolism and arm fatigue and neurocephalus. The prone position is a very common position, and I'm very familiar with doing that. There, you can also do a lateral or park bench position, which again, for me, it distorts the anatomy a little, so I don't mind doing the prone position. We have the neck in a military position with the neck tucked in, and the chin is clear. The arms are tucked in the body, strapped, the head secured in the Mayfield frame with eye protection, and the head is slightly up and the neck is horizontal. Skin, obviously, and shoulders are taped back out of the way for good, clear incision, and also too that everyone knows that there might be a need to drop the table if there's a risk of an air embolism with breach of the sinus. And also, if you're doing a sitting position, to practice maybe compression of the jugular veins with the surrounding staff. Considerations are, again, that we mentioned, air embolism, etc., and risk of brain swell and herniation if you're doing the patient prone. With the scalp decision, generally I tend to go down to the C2 region. Usually I have to take off the C1 vertebra because that's usually how low the tonsils go. And obviously in the dissection, you have to be careful of the vertebral artery. So stay within 1.5 centimetres from the midline on C1. With the bone flap, I start with using cerebellar retractors to get good exposure. I do up to a 3 by 3 centimetre craniectomy, using the burr holes initially with an M8 burr over the cerebellar hemispheres, and also then doing the foramen magnum separately with the M8 drill and using kerrison punches to make sure I've got that clear. I guess this stems from my doing any posterior fossa surgery, knowing that if you're going to get herniation or issues, that at least you can get the bone off very quickly through the foramen magnum. So I always make sure I've got the ability to take the bone off the foramen magnum quickly to get access to the cisterna magna. Then I use a craniotome to complete the bone flap, and also use the M8 burr to cut through the C1 laminectomy at the same time. Once I take off the bone, I dissect out the posterior atlanto-occipital membrane because I'm going to be making a cut through that dura in that region. Again, beware of the vertebral arteries, and beware of the sinuses by not going too high with your craniotomy. With the durotomy, it's a Y-shaped durotomy using wet clips as we're cutting, because there is the risk of the sinuses, the marginal sinus, and the occipital sinus can bleed profusely during the durotomy. Retract that, and I also raise the pericranial flap at the same time, and make sure that I keep that well hydrated. So then I bring in the microscope and start mobilizing the tonsils and do an adhesiolysis to expose foramen of Magendie. And I do look for the egress of CSF from the fourth ventricle. I don't plug the obex, and I try to avoid manipulating the floor of the fourth of the obex because of the association with vomiting. So again, you're going to be very close to the pica and the fourth ventricle. So I do coagulate the tonsils. This is a case of mine who I coagulated tonsils, and it does give you just that bit of extra room, and really has no extra morbidity that I found in operating. So I have watertight closure with the dural patch of the pericranium, and I use Tacoseal, sometimes Duracell at the top, but I think if you've got a watertight close, you don't need to use all the expensive adjuvant substances. And then we do a closure. I close the muscles lightly, gently, so that I think it helps with pain afterwards, because this can be a very painful operation. But then I close the fascia tight. And with respect to the post-op, the patient's sitting head up. They've got adequate analgesia, etc., antiemetics. I do have them in a soft collar because I find they tend to be able to position their head and relax, and so the muscles, which I think is a lot of the muscle spasm, is the pain that the patients experience after this sort of surgery. It just helps relax those extensor muscles. And sometimes I give some dexamethasone as well, again, just to make them feel a bit better. Staples out day 10, and I do an MRI for my and the patient's benefit, particularly if you've got a syrinx, because you find that the syrinx resolves quite quickly after a decompression. So complications are the CSF leak, just again, trying to make sure I get watertight closure, pseudomeningocele. Do we use if it becomes symptomatic, or if it's you get a leak, then to put in a lumbar drain fairly early, and you may need to put in a shunt if the pseudomeningocele is symptomatic and not transient. You can get symptoms of cerebellar slumping if your craniectomy is too big, so in which case then you can go back in and perhaps use some titanium mesh to help close the craniectomy site. I've noticed a few cases of a chemical type meningitis with colleagues who use a synthetic dural flap. Again, there's no evidence to show that except for the little bit that I showed earlier, that autologous is better, but that's why I tend to use the autologous flap. And of course, if you get bleeding or infection, there's a risk of hydrocephalus. And that's it.
Thank you. One time.